Hi guys, so today we're going to be talking about nutritional interventions, specifically in COVID-19 ICU patients. These patients are those in London of March 2020 during surges 1 and 2 of the COVID pandemic. So the problem at hand encompasses the COVID-19 pandemic during March 2020, which introduced an influx of ICU patients suffering from the newfound respiratory virus. Such an influx overwhelmed hospital staff in London, resulting in the frequent restructuring of nutritional support programs for patients. And such restructuring of these programs deviated from the standard of care, but deviated according to increased metabolic rates of patients, which led to malnourishment and rapid weight loss. But what nutritional issues did patients face as a result of COVID-19, in addition to issues introduced by the respiratory virus? So patients suffer from a marked hyperdynamic state with persistent pyrexia, so fever, leading to hypermetabolism and protein catabolism. Enteronutrition, or EN, intolerance also occurred in patients due to refractory hypoxemia, hypotension, and progression of multiple organ failure. And right here, we can see that infection of COVID-19 on a patient, which led to malnutrition in tandem with a compromised immune system, which further led to increased risk for disease. So before we go further, we're going to talk about certain definitions. These definitions include parenteral nutrition, or PN, which is nutrient delivery intravenously, so via IVs. Pyrexia, which is this medical term for fever. Enteral nutrition, or EN, which is the delivery of nutrients beyond the esophagus via feeding tubes and the oral intake of foods for special medical purposes. And then we can also talk about refractory hypoxemia, which is the inadequate arterial oxygenation despite optimal levels of inspired oxygen, which basically encompasses the fact that even though we are breathing the amount of oxygen required, we're not actually taking it into blood vessels, which then results in a lack of delivery of oxygen to muscles and organs that are required to keep us alive, which also results in multiple organ failure. So the intervention itself, the goal itself was to initiate nutritional intervention via local hospital COVID-19 ICU feeding protocol. But the actual goal, in tandem with that, was to prevent rapid weight loss and malnutrition, as there were increased metabolic rates observed within multiple patients, as well as malnutrition. Such protocol stated that feeding must start with high-protein enteronutrition product at 30 mils per hour for 6 hours, and afterwards the gastric residual volume, or GRV, would be taken. If the GRV was less than 500 mils, the rate of feeding was increased in order to meet target weight according to patient weight. Now, this varied due to different heights and BMIs of patients. However, as we said earlier within the semester, BMI isn't really applicable, at least within the US, because it's too general. It doesn't take into account the genetics and other attributes of various patients. And when we talk about target weights for various patients, which target weight can also vary, we also refer to it as ideal body weight. So the ideal body weight, or IBW, is essentially a measurement based on the patient's height calculated to BMI of 25 kilograms per meter squared. If a patient wasn't able to tolerate enteral nutrition, then parenteral nutrition was initiated. All ICU patients were screened by a dietitian each morning upon ICU admission, and however, only patients whose nutritional needs were not met in the ICU were required to undergo a dietary assessment within 48 hours of enteral or parenteral nutrition application. So before we go more in depth, we're going to talk about the guidelines of the actual study. So first, energy and protein requirements were set according to European Society of Parenteral and Enteral Nutrition, or ESPEN, which states a recommended target energy intake. So first, upon ICU admission or upon COVID-19 infection, patients were required to take in 20 kcal per kilogram per day of energy in the early phase, which would then be increased to 30 kcal per kilogram per day during the acute phase of critical illness. So after in the later stages after infection. And additionally, ICU patients were strictly placed on a high-protein diet to counter weight loss that was seen in light of increased metabolic rates and malnutrition. Further guidelines stated that patients with a BMI lower than 25 kilograms per meter squared were required to use actual weight, whereas ideal body weight was used for those with a BMI of ranging from 25 to 30 kilograms per meter squared. And adjusted body weight was used for those with a BMI larger than 30 kilograms per meter squared. Caloric intake was predicted using indirect calorimetry, and indirect calorimetry is essentially a method for measuring energy expenditure and intake via pulmonary exchanges. Excuse me. So was this study successful? There are multiple attributes of the study to take into account because COVID-19 isn't necessarily just a nutritional problem, but we are studying the nutritional deficits as a result of hospitalization due to the infection. So essentially the study stated that standardized feeding protocol failed to meet the nutritional needs of COVID-19 patients, specifically those in the ICU. The study separated patients during Surge 1 and Surge 2, and in patients during Surge 1, more patients required nutritional adjustments to alter caloric intake. Patients experienced increased rates of impaired renal function, and patients were required to have an adjusted fluid and electrolyte adjustment as well. Surge 2 patients experienced the same adjustments. However, these adjustments were made as a result of observations made by doctors in which patients were observed to have gastrointestinal dysfunction, whereas Surge 1, that wasn't necessarily observed. And if the overall patients, over 1/3 of admitted patients were malnourished and averaged a weight loss of about 7.9 kilograms during their ICU stay. This was primarily due to the sedentary lifestyle as a result of being incapacitated by the virus, as well as hypermetabolism and malnutrition. And then 73% of patients required dietetic intervention after being discharged, meaning that after leaving the hospital or the ICU, they were required to have further nutritional intervention by dietitians. Furthermore, 2/3 of patients lost over 5% of their body weight, whereas the other 1/3 lost over 10% of their body weight. Researchers suspected that disease severity, in addition to the time stay at the ICU, were contributing factors to rapid weight loss and malnourishment. Getting into the success rate of the study, no further weight loss occurred in patients outside of the ICU, which would indicate successful nutritional intervention. But we can't necessarily say the study was successful due to how new COVID-19 was. Additionally, we can say that the study had limitations according to it being a single center study, which means that the study was only conducted in a single hospital, which means no general applications can be applied to other individuals, specifically those outside of the UK or even globally. And then due to the observational design of the study, assumptions concerning causality cannot be made because no actual or tangible measurements were taken during the study. These measurements were purely observational, so what nurses, doctors, researchers observed in patients, which will lack in the reproducibility of this study. And unfortunately, due to how new COVID-19 is, we can't necessarily say that the nutritional deficits were the leading cause of death in COVID, because COVID-19 led to a lot of things, including leaving patients immunocompromised, patients who weren't able to have a great intake of oxygen, and just a lot of contributing factors. And concerning the concluding remarks of the study, over 1/3 of patients were malnourished upon ICU admission, like I said earlier in the presentation. Most patients were nutritionally compromised after leaving the ICU and required ongoing dietitian-led nutritional interventions. And ongoing interventions prevented further weight loss to combat malnourishment. An overall conclusion: the application of dietitian-led nutritional interventions in COVID-19 ICU patients increased the adequacy of nutritional delivery compared to standard ICU care. Because COVID-19 was a new disease, standard nutritional care was not applicable, as we saw various deficits according to a variety of patients. But more experimentation and results are required to adequately determine if the intervention was successful. Because this intervention occurred during the very beginning of the pandemic, not enough research can actually dictate whether or not this research was successful or even applicable. So more research must be taken more research must be conducted in order to actually determine whether or not this can be successful either in the future. And additionally, the study must produce evidence that is actually tangible. So taking actual measurements with calculations and being able to actually reproduce the study in order to determine whether or not this can be successful in the future and during future hospitalizations and complications due to COVID-19. And that is it. Thank you.